So, welcome this morning to CalAIM 301 Fiscal and Program Opportunities for Adult and Aging Programs. We are very excited to be able to bring some very specific information to our adult and aging programs and to really give you an opportunity to ask some questions and get some clarity regarding CalAIM and community supports that might be able to be utilized in your adult and aging programs and help with some of those more complex care needs. Today, our presenters are Baljit Hundal, Gretchen Schroeder, and Melissa Chavez. And I am going to go ahead and turn it over to them so that we can actually get started.
Great. Thank you, Sharon. Hi, everybody. Happy Friday. I hope you guys are getting a little bit of a break from the rain up north and maybe down south too. We are going to jump into our training. So we have built a series of trainings here, some 101s, 201s on CalAIM that really cover some of the basics around what these programs are, what is ECM, what is community supports. The 301, which we're going to do today, is going to dig a little bit deeper and really begin to explore these new funding streams more from a fiscal perspective and trying to see how do we integrate them into our existing funding streams, our existing services. So, really welcome folks' conversations. If you've been doing this for a while, I would love to hear your experiences. If you have questions, please jump in throughout the training. You can raise your hand, put it in the chat. We welcome all questions throughout the training. So one of the things we're going to focus on is how do we think about strategizing during our time here together? How do we think about integrating these into our services, into our county? So we'll focus on that today. Our learning objectives are really to increase readiness for all of us to engage in enhanced care management and community supports. And by engage, we don't mean become a provider. There's a couple different ways that you all can engage in these programs. I'm going to just put them out here now. We'll repeat them for the training, but provider is one way to engage. We also want you to think about becoming a referral partner. So do you have clients you work with that could benefit from these services? So how do you make referrals into these programs? You can also be a capacity builder. How do we shore up our community-based organizations? How do we partner differently? How do we let folks know these programs exist? So many different ways to engage. It's not just by becoming a provider. We also want to increase your understanding of the fiscal components of ECM and community supports so we can think about the trade-offs of doing these programs versus other programs. We also know some funding streams are sunsetting. So how can ECM and community support start to shore up those services? And then we have some next steps for you all to walk away with as you begin to think about how you can become involved in ECM and community supports. As always, our focus is the client, and so want to make sure that we hold the client in the center of our conversations here today. How do we improve access to services for our clients and their families? How do we support them in getting their needs met? So we'll keep that at the forefront of our time today. Of course, we have a robust agenda, so we will be going through these. And if you need more information, again, put it in the chat. We can also refer you to our 101 and 201 CalAIM presentations that are recorded on the CFPI website. So you can check those out if you need more background information. So we're going to talk about Medi-Cal transformation. We're going to talk about ECM and community supports. Pretty quick overview of those two programs. We do have a case study we're going to jump into in the middle of our training here today. And then we're going to really dig a little bit deeper into the fiscal components of ECM and community supports. And of course, as I mentioned earlier, come back to what roles can counties play in these two programs. All right, with that, we'll jump into Medi-Cal transformation or CalAIM. You will see these two terms used interchangeably. CalAIM is the old term, which stands for California Advancing and Innovating Medi-Cal. The state has tried to rebrand it to Medi-Cal transformation, but that hasn't quite stuck. So you will see both of these terms used interchangeably. So first off, I just want to do a quick level set of what is Medi-Cal, because that will set the stage for how these programs are being managed throughout the state. So as you all probably know, Medi-Cal is the state's Medicaid program, and it's really that public health insurance program that provides needed healthcare services for qualifying individuals. Who are those qualifying individuals? They're typically low-income individuals and families, though there are categories of certain diseases, of certain conditions that do qualify folks for Medi-Cal as well. Important to note, the financing of Medi-Cal, very basic, is split 50-50 between the federal government and the state. There are certain Medi-Cal populations that are covered higher by the feds than by the state, and there are some programs that have different funding splits. But generally speaking, it's going to be a 50-50 match. What's key for our conversation here today is the enrollment in Medi-Cal. So from any given month, you see about 15 million individuals in California enrolled in Medi-Cal. Of those, 90 to 95% of them are enrolled in Medi-Cal managed care. So when the state thought about how do we really make the greatest impact and improve Medi-Cal, it was through the managed care program. And so that is why we see CalAIM really being launched and managed through the Medi-Cal managed care plans instead of directly through the state. What this also means is for folks to take advantage of ECM and community supports, they need to be enrolled in Medi-Cal managed care. So the state launched this Medi-Cal transformation, this CalAIM initiative back in 2022. It's a multi-year effort to really change how healthcare is delivered through the Medi-Cal managed care plan system. They're trying to do a more coordinated, person-centered, and equitable health system, trying to address physical and mental health needs, trying to improve and integrate care, which I think all of us can see is a great need for folks with complex healthcare conditions. They also want to really be a catalyst for equity and justice. So those are the very lofty goals the state has put out for Medi-Cal transformation. CalAIM has 11 different initiatives under the umbrella here. We are going to focus on the top four, the ones in blue that are community supports, enhanced care management, incentive payment program or IPP, as well as providing access and transforming health or the PATH program. The others are very important and they're often structured a little bit differently than the top four, but we're just going to focus today on those top four. So a lot of you may be wondering, why does CalAIM matter? Why do I need to pay attention to this? How is this going to help me and my clients? And I think the things that I think about, and of course, if you guys have additional ones as you've done your work, please throw them in the chat, but really looking at new revenue streams, Medi-Cal revenue streams, which are sustainable funding streams coming into the county. And so this is new money coming in to support our most vulnerable, our most complex patients. We also have these new benefits and services that are available to vulnerable populations. So we know that there's a need for additional care management services for a lot of our folks that we work with. We know there's a huge need for housing navigation services. And so these programs can offer those two services. And then one of the things that we're starting to see this really come to fruition is this opportunity to break down silos between different systems of care. So how do we all start to work together, coordinate care, and really keep that client as the center of the work that we're doing? So we're starting to see this really come to fruition. It's really exciting, but it's been very rewarding to see those silos start to be broken down bit by bit. It's a slow process, but it is happening. ECM and community supports are not standalone initiatives. They do align with several other programs that you guys may be involved in. Here are some of the ones that are listed here. And so what we think about here, and I'll take IHSS as an example here, is that some of this ECM and community support services can wrap around IHSS, so may fill some of the gaps as folks wait for their IHSS application to be approved. And so just thinking about how do we integrate these services to really best serve our client. So it may not be one or the other. It may be, what do we need for these 2 months while we wait for IHSS to be approved? What do we need after our programs have worked with the client? So thinking about these as a continuum of care. So let's get specific here with enhanced care management or ECM. So ECM is a Medi-Cal benefit that is important. So it is more sustainable than community supports. And this new Medi-Cal benefit is really intended to break down the walls of healthcare. So we want to see healthcare being delivered not just in a hospital or clinic setting, but in the community. And we know that folks who are the most vulnerable, have the most complex health conditions, they really have to access multiple systems of care. So how do we help them coordinate that care? How do we help them make their appointments, get their prescriptions filled, coordinate transportation? All of that is part of ECM. So we have a lead care manager as part of the ECM program who really does that comprehensive care management, who coordinates health and health-related services and makes referrals. So sometimes we have folks who may be eligible for different types of assistance, but haven't accessed that yet. Their ECM lead care manager can help them get on SSI, can help them get general assistance, can help them look at housing programs that may meet their needs. So that lead care manager is really going to be central to helping them become more stable and hopefully more independent. We also want to make sure that we're focusing on quality of care. So how do we, really work together to ensure that individual doesn't fall through the cracks? And so that's part of the ECM lead care manager's role as well. When the state thought about ECM, they really wanted to target about the top 3 to 5% of the Medi-Cal managed care population. So the folks that are the most vulnerable, have the most complex healthcare needs, and are also the most expensive for the Medi-Cal system. How do we start to work with them to really stabilize them, improve their health, reduce costs, et cetera, et cetera? And so ECM was created to be that top level of care management services in the Medi-Cal managed care world. There also are 2 other care coordination or care management services that managed care plans do offer. So if folks don't qualify for ECM, they may qualify for complex care management, which is offered through the Medi-Cal managed care plans. And then there's also some basic population health management, which is often like the health education, don't eat or don't smoke, eat healthy meals, all that good stuff that we probably have taken advantage of ourselves. So there are different levels of care management available through Medi-Cal managed care, but ECM is really targeting the top 3 to 5%. The other thing that ECM can help with is transitional care services. So as individuals transition out of a hospital, out of a SNF, out of jail, transitional care services can help them really get the care they need, get stabilized in their new setting, and make sure that all the linkages have been set up again. So that's an important piece of ECM. One thing I do want to highlight here is the state has put forth, they want to have 3 to 5% of the Medi-Cal managed care plan population enrolled in ECM. We're hovering between 1% and 2% in the state right now. So there still are a lot of people out there that the state believes qualify for ECM, could benefit from ECM that have not yet been enrolled. So we're really trying to emphasize, how do we increase referrals? How do we work with trusted providers to ensure they can make the referrals into these programs for folks that do need it and qualify? So who is eligible for ECM? The state has developed 9 different populations of focus that they rolled out over the past 2 years. All 9 are currently live. Some are just for adults, some are just for children and youth, but you can see the different populations of focus here. What's going to be important is that if you make a referral into ECM, or if you want to become an ECM provider, you have to specify which population of focus your client qualifies for ECM. And if you're going to be a provider, which populations of focus do you want to serve that you have expertise with? So it's going to be important to really become more familiar with these populations of focus. I know that Baljeet put in the chat, there's a policy guide for ECM that has all of the eligibility criteria for each population of focus. And that really is the reference point for all ECM policies. So I encourage you all to check that out. And if you're wondering about, who can qualify for these different populations of focus, it does list those criteria very clearly. To be an ECM provider, and for those who are thinking about it, the state is really wanting to have that be a community-based provider, which can include county departments. So folks that are local, that have people on the ground working with individuals face-to-face, that is one of the goals. That's not possible in every county, but that is one of the goals of ECM, is doing that face-to-face encounter. We want to have folks who have expertise with these populations, who understand their needs, understand what services exist in the community they're living in. And then they want to have folks that, of course, can do the Medi-Cal billing and claiming, which is a whole unique set of skills that not every organization or county department is familiar with. So there's been a very steep learning curve for a lot of organizations to learn about Medi-Cal and how to engage with Medi-Cal managed care plans. So that's been the challenging piece, I think, for a lot of organizations so far. CalAIM or ECM is administered. I should be specific here because different programs go different ways, but it really is the state contracts with the Medi-Cal managed care plans for ECM. And then really is hands off with the Medi-Cal managed care plans of who they contract with for ECM, what rates they pay, what payment models they use. They have to follow the policies, but it really is the Medi-Cal managed care plans who dictate rates, who dictate number of providers, et cetera, et cetera. So I strongly encourage all of you, even if you're not going to be a provider, to get to know your Medi-Cal managed care plan partners. They are really important in this new space that we're working in. I think can only benefit both of you to understand each other and to work collaboratively, either as a provider or as a referral partner, as just a collaborative partner in this space. Let's jump into community supports. Community supports are a little bit different than ECM. They are not Medi-Cal benefits, so that's a key thing to be aware of. They're supposed to be cost-saving programs. So instead of a Medi-Cal covered benefit, you can do community supports, which hopefully will better meet the client's needs and also save the state money. So they're optional services. So every county and every managed care plan can offer any of the 14 pre-approved community support services that are live now. And so you will see differences within one county between what one managed care plan offers and what another offers. So it's really important to understand what is currently available. We do have a 15th community support, which was just approved by the federal government in December. It is going to launch as an optional service on July 1st of this year, and then be mandatory January 1st of next year. And that is transitional rent. You'll see that here at the bottom. And it's very exciting. We're still learning more about transitional rent, but it will be an opportunity to provide up to 6 months worth of rental assistance to qualifying individuals. Again, optional to start for managed care plans July of this year, and then mandatory January 1st of next year. But we did want to just cover very high level some of the community support services that are out there. We've done some bucketing here. The easiest bucket is the housing services. There are quite a number of housing support services available. The top one will be that housing transition. So really helping folks apply for a housing voucher, look for a housing unit, do the housing application, go meet the landlords. All of that good stuff can really be part of housing transition navigation up here. And that is open to folks who are either experiencing homelessness or at risk of homelessness. We also have housing deposits, which does provide some money. The state level is about $5,000 that can help folks really do their security deposits, help with setting up utilities, and then a few other things. If you need a hospital bed or refrigerator for your insulin, housing deposits can be used for that as well. And then once you are already housed, we do have a housing service called Housing Tenancy and Sustaining Services, which is to help keep you housed. And so what kind of skills do you need to learn? How do we support you working with the landlord to stay in your housing unit? So that's also a very valuable service available through community supports. And then we do have some services here that are for folks who may be coming out of the hospital, for example, recuperative care. That's medical respite. So maybe you went in and had a wound at the hospital and you are being discharged, but it's really not a good idea for folks to be discharged back to the street if they're experiencing homelessness. So how do we give them some more time in a clean environment to fully recover? So that would be recuperative care services. And then we also have short-term post-hospitalization housing, which again is a way to help folks not be discharged from the hospital back to the streets. So really trying to shore up folks' recovery time and also give them a chance to maybe work on their housing plan and maybe even help get them into housing during their time in those two community support services. Our next little summary here, bucket, are going to be 3 different community support services: asthma remediation, sobering centers, and medically tailored meals. All of these are available to adult populations. And I will say that medically tailored meals is actually the most popular community support service across the state right now. It's really showing incredible results in terms of helping folks stabilize their health. And so if you have someone who maybe is diabetic or maybe needs some additional support with their nutrition for a medical condition. Medically tailored meals can provide up to 2 meals delivered to your doorstep every day. So that's really exciting for some of our populations. And then our third bucket of community supports, kind of a hodgepodge here. We do have the top one is respite services, so trying to give caregivers respite. So thinking about how that could benefit the populations you work with. You have to be living in the community to qualify for that, and it is episodic and short-term caregiver respite. We do have day habilitation programs, which is really targeting folks who need additional support in learning to live independently, maybe folks who have experienced homelessness, and maybe other populations who supports and trainings and skills to live in the community independently. We have a couple of different ones here of trying to make sure that we can have folks live in the least restrictive environment possible that's safe for them, that they want to live in. So looking at how do we have folks transition from nursing facilities to assisted living? How do we have folks that maybe move back into the community, back into a housing unit? So looking at how that can be supported through community supports. And there are some dollars that are tied to at least the community transition services, so trying to help folks get back into the community safely. And then we also have personal care and homemaker services here, and that's really looking, and that's part of the wraparound for IHSS. So these are folks that can help fill that gap with IHSS, can do additional support afterwards, and so they may be someone to think about. And there are several different organizations across the state doing personal care and homemaker services. Some serve multiple counties, and some are very, very local. So good to get to know those folks. And then the last one we have listed here is environmental accessibility adaptations. And that's really trying to keep folks again in their home as long as possible, as safely possible. So that can, help with creating wheelchair ramps, putting grab bars in a home, really trying to make that home safer for individuals to stay there longer if they want to. And there's some dollars associated with that as well. Any questions on our very, very brief high-level overview of community supports or ECM right now? Again, put it in the chat, raise your hand, whatever works best for you. Yeah, Gwendolyn.
Sure. So when you said that the Medi-Cal managed care plans are trying to serve the top 3 to 5% of the population, right, with ECM,
Yep.
and they need more referrals.
Yep.
Is there a way to identify those people to see who those people are? Because we don't know of our IHSS population in Solano County who would qualify for those supports, because we don't know if they're in that top 3 to 5%. So it seems like if we're making referrals and we're missing the mark, we can refer 10 people, but how do we know that the measures that the companies are using are the same as what we are doing? Does that make sense?
Yeah, no, that's a great question.
How do we make a match?
Yeah, and I think that's been a challenge that we've been experiencing over the past 3 years of these programs. So the state has set a goal of 3 to 5%, and that's kind of trying to create some level of measurement here, which we're not meeting. The managed care plans have to follow the state's policy guidelines as to who's eligible under each population of focus. So if I were looking to make referrals, I would look at that policy guide that Baljeet dropped in to see if the folks that I'm working with qualify for any of those populations of focus. So it could be folks who are at risk of institutional care. It could be folks who are experiencing homelessness. There's different populations of focus that you may have individuals qualify for. I wouldn't worry so much about that top 3 to 5%. I would worry more about, do they meet those eligibility requirements?
Let me ask the question a little differently.
Sure.
Okay. So if you have 10 people that are qualified in your system on the Medi-Cal managed care side, but I have another 10 people according to this general guideline that I think are qualified, right? What are the chances that there's a match between the 10 people I'm looking at based on this general guideline and your 10 people on your list?
So that's not how it actually is working. So we're just trying to identify all the folks that are eligible for these programs based on those policy guidelines. And so We have not yet reached anywhere near the cap of 5%. So there's really no scarcity of spots right now. So if you
Okay.
have 10 folks you think are eligible, I would really encourage you to refer them. Part of
Okay.
the referral form asks you to identify which population of focus and various criteria to support that. So we don't see a lot of denials with referral forms that are actually filled out completely by providers who understand the program and understand what the criteria are.
Okay. And how do the last question is how do the clients actually know that this is a benefit that they could take advantage of?
That's $1 million question.
Okay.
So the plans do their marketing, which, as we probably have all read and ignored, a lot of flyers we get in the mail or folks tell us about all these great services. A lot of folks don't believe that it's true. So there's a lot of, really, it's been a huge challenge. How do we get folks to know these programs exist, to trust that they're real, and then to accept eligibility or enrollment for those services? So one of the things that we talk a lot about across the state is how do we market these to folks, not just to the managed care plans or the providers, but how do we market them to the consumers? How do we let them know this really could help them? And that is why I think it's so important that as counties work with clients who are vulnerable, who may meet these eligibility criteria, that you're their trusted provider. So you sharing with them how this may help them. And if you can make a referral to a trusted provider that you know can really do this job and do it well, that's going to go a long way.
Thank you very much. I did have a third question. If you want me to wait for it, I can. If someone else
You're on
has
right
it.
now, and then we'll go to Mara in just a minute. So yeah, go ahead,
Yeah.
Gwendolyn.
So long-term supportive services is a or affordable long-term supportive services housing is an issue for us in Solano County. Can you point to the ways, again, I know you had different buckets of where that part would fit in CalAIM, but can you just point to it and talk a moment about how that may be being addressed with CalAIM?
So I think the biggest one is going to be that housing transition navigation services, the top
Okay.
one here in this chart. And those are folks who are going to be working with an individual to develop a housing plan. So what are their goals? What are their needs? And then helping them locate the services and often locate funding to pay for that. So it could be applying for vouchers. It could be applying for other funding sources to help them get into housing. So it's a wide variety of services that can fall under this umbrella of housing navigation services.
So they don't have to be homeless. This could just be a person who cannot live on their own any longer because of functional.
They could be at risk of homelessness. So
Okay.
if some of our long-term care clients, we probably think they could be at risk of being homeless. And we're starting to see the adult population, especially older adults, they're becoming homeless at a really fast rate right now. So there's a lot of concern about how do we work with them to prevent them from going on the streets, because once they're out there, it's really hard to stay healthy, especially for older adults.
Thank you so much, Gretchen.
Thank you so much. All right, Mara, thank you for your patience.
Yeah, so I had a question. I work in Santa Cruz County and I wanted to know if there is a way to get a list of all active ECM providers and the services that they provide.
So ECM is kind of a bucket of 7 different services, which we didn't cover, but is in one of our 201 CalAIM trainings and is also in the policy guide. Every managed care plan should be listing all of their ECM providers and which populations they serve on their website. The other key thing I'm going to point you to is each county has collaboratives that are focused on ECM and community supports that the state funds. And those collaboratives often have provider registries or directories that list all the different providers, contact names. And so I know Santa Cruz is a very robust collaborative, so I would really encourage you to register for that. And I don't know if we can drop the link for those collaboratives in the chat. But those are really, really helpful getting to the providers in your county.
Thank you.
All right. Any more questions? All right. Well, with that, we're going to move on to our case study and we're going to meet David. Baljeet, I'll turn it over to you.
Great, thank you. And I was looking for that CPI link, so if you could do that, that would be great. So let's apply this to a situation that many of you or your staff might be dealing with in your county, and how do you integrate ECM and CS services into this? So we have David here. David is a 62-year-old male who is experiencing chronic homelessness for the past 3 years. He also has health care needs, which includes type 2 diabetes and hypertension, and these are continuing to get worse due to medication and food issues. He has limited mobility from an untreated workplace injury and experiences chronic joint pain. He's frequently hospitalized due to complications from his medical conditions, but once done at the hospital, he is just discharged back to the streets. He struggles with undiagnosed depression and occasional alcohol use to cope with stress. And then currently he is sleeping in a tent behind a gas station and relies on food pantries for meals. So some of the services that he is receiving currently includes he's being connected to a FQHC, so a health clinic for primary care, but he is having trouble attending appointments. He does have a street outreach worker that has been trying to link him to housing, navigation services. Again, he is going to food pantries, but struggles with access to nutritious meals. He has no stable income at this time, is eligible for general assistance, but again, has not been able to follow that through. And then he has had multiple touch points with APS. And so he has had some interface there, and then he has tried to come on to IHSS, but again, probably due to his current circumstances, has not been able to complete that process. So and we're going to do 3 different scenarios of following David to show you where ECM and community supports could really integrate with some of the county programs that a lot of you are providing to our adult population. So in this, based on right now in this current situation that he's in, it's all about early intervention, right? Getting to him fast, identifying that he is an individual that could use higher level of supports and services as part of CalAIM, and that nobody is really following him from a case management standpoint at this time. And so he would actually qualify for enhanced case management under the population of focus, which is individuals experiencing homelessness. And I just want to share some of the definition of that real quick here. So we are talking about someone who is experiencing homelessness and is meeting, and under that is meeting one of the following conditions. So they lack a fixed, regular, and adequate nighttime residence, or they have a primary residence that is a public or private place, but is not designated for or typically used as a regular sleeping accommodations for human beings. And this could include a car, park, abandoned building, bus or train station, airport or camping ground. Another could be that he's living in a supervised public or private operated shelter. And this is temporary. And so he needs help to move on to something more permanent. So these are some of the reasons why someone would qualify under the population of focus of homelessness. Now, in addition to meeting the homelessness criteria, he would also have to show that he had at least one complex physical, behavioral, or developmental need, which is unable to self-manage. And in this situation, we have medical needs for him as well. And then we're kind of getting into some behavioral health issues with his depression and maybe some of his dependence on alcohol. And so he definitely qualifies for ECM under this category. Another potential population of focus that we could look at for him is under the adults with high utilizers of our emergency room departments or our skilled nursing facilities. And so under that, he would have to have had at least 5 or more emergency room visits in a 6-month period. That could have been avoided with outpatient care or improved treatment. So clearly he fits under the homelessness population of focus, but he may also qualify under the high utilizer population of focus if he's in and out of the hospital, meeting that clear definition eligibility. And so here, we're saying that his someone from the hospital could refer him to ECM, or maybe even his primary care physician, and even APS, right? Maybe as part of their touch point, they've identified him as needing this additional service and can refer him as well. So next, he gets assigned to ECM. What happens? So the ECM lead care manager is going to meet him where he's at, right? And so that could be where he's currently calling home, or it could be at a local shelter. They are then going to do an assessment with him and identify what his needs are and come up with a care plan for him. So a treatment plan for him of what are his current top priorities and what are things that they may need to refer to other providers to get him assistance. So based on his needs right now, he needs to get in to see a doctor more frequently to deal with his diabetes and hypertension. Also, probably needs to be referred to behavioral health services to manage his depression and to really assess if we're dealing with some SUD issues here or not. And then the ECM lead care manager could also start looking at all of those 14 community supports to see what additional services and supports he would need there, and would make those referrals for him as well. And then they could help him with the GA application. They could help him with the IHSS application and process. And so the lead care manager is going to be that person that's going to kind of walk him through all of these processes. So some of the community supports for David that really kind of stand out for him right now. One potentially is the medically tailored meals, getting him meals that are more nutritious, maybe meals that are really going to help with his diabetes. And then the housing transition navigation services, right? Getting him off the streets, out of that gas station where he's putting up a tent, and into something either temporary that could move into something more permanent, but at least getting him off the streets and being sheltered inside.
Well, Sheet, I'm just going to pause for a minute here. We did have a question that I think would be great to answer during this section here. And Allison asked, I've just returned to APS as a supervisor in San Luis Obispo County. How do social workers and APS refer to ECM? I'm going to also add in community supports here as well.
Yeah, so for ECM, the state did develop a standardized ECM referral form that can be completed and submitted to his managed care plan, or you can go on the managed care plan website and complete it there. And then the same can be done for community supports. Now, I think what I found is that a managed care plan may have a different form based on which community support that you're seeking to enroll him in, but all of that information, like Gretchen said earlier, is on that managed care plans website. So one of the first things when you're working with an individual that you feel could qualify and benefit from ECM or CS is find out first, are they on Medi-Cal? And if they are on Medi-Cal, are they in a managed care plan? And if they're not, how do we help them to get into a managed care plan if they're eligible for that enrollment? Now, one of the things that we have found as we're, kind of working through how to get folks into these services is some of our older adults may have a share of cost Medi-Cal, and that makes them ineligible to enroll in a managed care plan. Besides that, though, that they should be able to enroll in a managed care plan in your county. And some are automatically enrolled because there is no straight or fee-for-service Medi-Cal. There is only the managed care plan. And so they're automatically enrolled into that MCP. Hopefully that answers the question. Great. All right, so now let's move on with scenario 2. And so we're kind of upping the ante on David and how he's doing and kind of following him. And so his blood sugars are, spiking dangerously, leading to severe dehydration and a foot ulcer, which ultimately lands him back in the emergency room. And he's been admitted for 4 days. So taking what we've already done in scenario 1, we're going to add that when he's ready to be discharged from this recent emergency room visit and hospitalization, he would actually now qualify for the community support of short-term post-hospitalization housing. And so that will allow him to go to another medical facility and continue to get his medical needs met, because it's probably one of those situations where he needs to continue to be monitored and assisted. The other thing here to mention is that another additional service and benefit under CalAIM that the managed care plans are responsible for is that when folks end up in our emergency rooms or have hospital stays, there is a transitional care service that has to be initiated in order for that discharge planning to occur and to be successful. And then the managed care plan has to follow that individual for up to 30 days post-discharge to make sure that that transition to either a nursing facility, a long-term care facility, or back home, or in this situation to a short-term post-hospitalization housing setting is successful. Now, because he already has ECM services and he's enrolled, that will fall on the ECM lead care manager. For individuals that don't have ECM and they end up in the hospital and then they need to be discharged, the MCP typically takes on that role. But since he has ECM, the ECM lead care manager will provide that transitional care services so that he can move on to the next living environment that he needs for his continued physical health and well-being to improve. So just to continue on with scenario 2, so he's going to be placed in a temporary housing facility for up to 6 months where he can continue to get his healthcare needs met and be in a safe, stable environment. The ECM care manager is going to continue to work with a housing specialist to find something more permanent for him. They're going to continue to make sure that his medical needs, his physical health needs are being met. Continue to coordinate with behavioral health if those are services that he needs. And again, at this point, we're hoping that his IHSS application is approved and that the ECM care manager could also assist with trying to find a provider for him and work in tangent with IHSS to help with that and the public authority. And then once he does find housing, the housing deposits community supports could be initiated and he could be enrolled in that. And that will make him eligible for a security deposit, first month's rent assistance, utilities, all of these great things. Besides, though, an ongoing rental payment, that's what transitional rent is going to do. And then if he finds a place and he needs additional modifications done in the home, there is a community support called environmental accessibility adaptations, and that could be utilized to pay for some of the things that he may need, which could include grab bars, anything that would help him remain in that home. So, and that's up to $7,500 per lifetime per member. And the housing deposits is up to $5,000. So your question, does a person who is at risk of homelessness meet eligibility for ECM? Would they have to meet one of the other? No. So you only have to meet one population of focus, but we're finding that some of our clients are maybe going to meet more than one population of focus. And when you complete the referral form, you can check off the ones that you think they apply for. Definitely. But they only have to meet one. Let's see. So third scenario, so we're now a little bit further on with David. He's come out of his short-term hospitalization housing, and his team has been able to find him a temporary housing unit. He's doing well, but his chronic conditions still put him at risk for long-term institutionalization in a skilled nursing facility if things don't continue to, move along the stability line. But through his ECM and his community supports, he is finally able to find a permanent supportive housing in a small apartment. And so here he's now able to be connected to in-home care supportive services to assist with daily activities and needs that he has. He's able to continue to meet his behavioral health needs. And then he's also been enrolled in a chronic disease self-management program to prevent future hospitalizations. One of the great things about ECM and getting them involved with our clients who have significant health needs is that ECM lead care management has access or kind of is a liaison with that MCP, that managed care plan, to say, this is what this person needs. What else do you have that I can offer this member? And so there are a lot of programs within the managed care plan that the ECM lead care manager could help connect the member with the client. And then as he's moving into more permanent housing, he would also get the housing sustaining, which is to, you found permanent housing, now let's make sure you stay there. If he is institutionalized or potentially may fall, we're saying that he may fall into that category. We also have the nursing facility transition services as a community support. We also have personal care and homemaker services to help him in his new permanent home. All of this combined is helping to keep him housed, helping him to meet his physical health needs as well as his behavioral health needs, and really helping to provide that whole person support and services to our Medi-Cal member, where it's not just physical health or it's not just behavioral health. We also have to look at the social determinants of health, and that if we're not also taking care of those, you can only move so far with meeting their physical and behavioral health needs. So through CalAIM and through ECM and community supports, David has, been successfully linked to services, resources from physical health, from behavioral health. And so now we're seeing, he's not ending up in the ER unnecessarily, and that we're avoiding long-term care for him. He's receiving wraparound support from his ECM lead care manager, from the community supports, and including IHSS in that, right? And this is an opportunity where care coordination between all these entities could really improve the ultimate outcomes for this member. It would help with making sure that he's continuously housed permanently, making sure his physical health needs don't decline any further, making sure that he's receiving IHSS and that he has a provider and that that provider is meeting his needs. So again, this is where care coordination would be really important, but kind of highlights the need for it and how successful it can be for that ultimate member when we're all coming to the table to talk about how we're going to support this member. I'm just going to give it a minute to see if we have any questions about this scenario. Yeah, so the personal care services. So it's, we can put the definition of it in the chat, but basically, it could be utilized for several different reasons. One, it could be utilized if you're waiting to get on IHSS, and as you're waiting for that approval, you could initiate this. You could also initiate it if the hours that you have been approved are not enough. And so you could also utilize it for that as well. Now, is it seen as an alternative resource? That is something that we need to continue to lift up to CDSS and DHCS to get more clarity around that. Because I know that's come up in another presentation that we've done, the question around alternative resource and some of these community supports. All right, I guess we can move on. Okay, so we're going to talk about operationalizing ECM and community supports, cover a little bit of time there. So what role does the managed care plans play in this? Ultimately, in order to get the services and benefits under CalAIM, the member has to be enrolled in a managed care plan. So the managed care plans play a significant role in the implementation and rollout of CalAIM and all the benefits under it throughout the state. Now, this slide kind of shows you where, where it's coming from. So it comes from DHCS at the state level. They then have contracted with the Medi-Cal managed care plans across the state. And then the Medi-Cal managed care plans are then a big part of their responsibility is making sure that they have enough providers in each county for the particular populations of focus and for each community support that they say they're going to offer in each county. And so that's a huge lift for them. And they've been doing this now since 2022. But I would definitely say initially when I came into CalAIM, that's all they talked about was how do we get providers? Like keep referring us, vendors that you work with. How do we get more and more providers? They are responsible to make sure that providers have the experience and expertise in that community support that they want to contract with or in that ECM population of focus that they want to work with. And so that is a vetting process that the state has placed that responsibility on the managed care plans. So some plans, so this slide here kind of talks about the rates and how the plans are paying for ECM or community supports if you decide to come on as a provider. I'm not going to spend too much time here, but so there are some plans are also using value-based purchasing for payment models. So there is no standard rate though for these services, and so you'll see different rates based on county, and it's kind of all over the place. And the state hasn't really stepped into this yet, but I think they may look at this year because it's one of the I hate to use the word complaint, but it is one of the issues that a lot of the providers have been lifting up is that the rates actually don't really cover a lot of the cost involved. And then for community support, same thing. There is some limited state guidance, but again, MCPs are really developing their own rates and it could vary county by county. Now, does that mean that you have to just take the rate that the MCP is offering? No, it's part of negotiation, right? And we have heard some providers getting higher rates based on maybe they're going to offer, maybe they're going to meet a population of focus that is underserved in that county, or it's a community support that no other provider is willing to come into. It could be that, you know, if you're in a rural county, you have more negotiation power, because rural counties right now are probably one of the most underserved areas in the state for an abundance of providers for ECM and community support. So there is some leeway here around the rates. But you got to have the conversation, right? You got to build those relationships first. So just to kind of share from this slide, so DHCS is going to start looking at providing more oversight and monitoring of managed care plans for ECM and CS beginning this year. And then also the managed care plans are also going to start looking at how do we do audits, or audits come with such a negative connotation, right? Excuse me, how do they kind of do quality insurance reviews? There we go. That's a better way to say it, of ECM community supports, because we are also seeing that there is not consistency across providers and how these services are being provided. And so there will be some more around that from the state and the managed care plans. And then some counties and some providers are beginning to look at hub models. And so Kaiser has a kind of a hub model already with some of its ECM populations of focus. So there's one that's targeting child and youth populations of focus, and I think there's a couple for the adult population of focus. And this is where you have an administrative entity that does the contracting, does the billing, the claiming, some of that quality assurance, so that the provider can just provide the service and not have to worry about that stuff. And so there's a lot of ways that folks can come into this, either to help build capacity or to actually be a provider. So let's talk about CalAIM funding opportunities. What if you are interested in coming on as a provider, or you know a community-based organization that you feel would be best suited to provide this in your county because you already work with them and you feel that they could meet either one of the ECM populations of focus, or they could really do a good job in one of the community supports. So there is there is funding through the managed care plan, though it's kind of limited now, and I think it's nearly gone. But you can ask the MCP in your county about IPP funding, which is the Incentive Payment Program, and that was to help providers come on as ECM and CS providers. So that's one opportunity. But again, some MCPs may have already run out of the funding here. It's providers really have to ask their MCPs. And then the state has put in a lot of funding opportunities around building capacity for this, and that is through the PATH funding. And PATH is providing access and transforming health. And so we do have cited dollars, and we recently did a cited brown bag webinar. Gretchen did a fabulous job of walking us through the round 4 application, which is live today. And the deadline was extended through, I want to say May 6th, right? Yeah. May 2nd, I'm sorry. And so this is a grant funding through the state to, again, come in as an ECM, a community supports provider, and it's funding that could help assist with staffing, rent, purchase of vehicles or other equipment, coming onto electronic health records. There's a lot of things that you can do here through this funding. Now, this is the last round of funding for this, and so it's only for a year once awarded, and so you really have to be ready to go if you apply for this. They extended the deadline to also include any providers that want to come in on that 15 community support, which is transitional rent. And then they do have some, for each round, they've always had priorities of who they're trying to target for these funds. And so here you'll see they're targeting rural counties. They're targeting counties that didn't get a lot of prior cited funding. They're targeting local CBOs, right? Some of our community supports are being provided by these large organizations that may or may not have a presence in our state, but they're able to provide it across the state. And so they're now looking at, let's build that local CBO capacity. And then populations of focus that they're really focused on, both equity, justice involved. So all of that information there on this slide. And again, we did provide a cited brown bag webinar where we went into more of this, and I believe it's on the CFPIC. Yep, there we go. Melissa just added it. It's on the CFPIC website if you're interested. And then just real quick, not going to go into this much because we need to get more information from the state, but on the 15th community support that was approved late last year, this is a little bit different than the other community supports, in which the other community supports, you didn't need to meet a population of focus. Those community supports are for anyone that's on Medi-Cal and in their managed care plan. Populations of focus have been really for the ECM benefit, not for the community support. But under the 15th community support of transitional rent, they are adopting a population of focus, and it's also going to be in line with how they roll this out. So they've identified 8 populations of focus, which are here on the slide, and we'll get more information about, well, you know, what are the definitions here? What are the eligibilities for each of these? They're looking to go live with this starting July 1st as an option for managed care plans to come in with the first population of focus, and then it would be mandatory January 1st, 2026 for all managed care plans with that first population of focus behavioral health. And then they'll have a timeline of how they're going to introduce the rest of the populations of focus. They did a similar approach with ECM populations of focus as well. So they rolled out the first 3 populations of focus back in January 2022, and then they staggered the rest. And the last ones have been, I want to say, both equity and justice involved. So recognizing that, you know, just trying to do everything at once is probably going to be a huge lift. And so they're really strategizing how they're going to roll this out. And we'll probably have additional webinars and information about transitional rent as we get more guidance on it. So another thing under the PATH initiative, which is a big part of the CalAIM initiative, and we want to talk this up. This is the Technical Assistance Marketplace. And so this is free to folks who want to come into the CalAIM space. And it doesn't, I would say it's not necessarily if you want to come on as just a provider. There are multiple ways that you can come in on this. Maybe you want to help build local capacity. Maybe you want to figure out how to build that network of care in your county, you know, the care coordination and all of that. So this is free to folks that want to come on to this, free to entities that want to come on to this. The state then has contracted with technical assistance vendors who will provide that technical assistance support and assistance. And you get a set number of hours of, you know, a project and you work through it with that vendor. Just as a side note, CFPIC has applied to be a vendor through the TA marketplace. Fingers crossed that we get our application approved. And so we will be one of the entities that you could essentially work with to help you look at how you're going to come into the CalAIM space. Let's see, next slide. I think this is Melissa, so I'm going to turn it over to you, Melissa.
Thanks, Belgi. Okay, so what role does counties play? And so I'm going to kind of switch gears to all of the great information shared, but what does it mean specifically to our county and as it relates to the funding and fiscal? So first off, we got to kind of think about how CalAIM aligns with your county's kind of strategic priorities. We want to do things usually piecemeal because CalAIM brings a lot of opportunity, but also some challenges, right? And so some opportunities include different and new funding streams, better core coordination for our clients, and even a bit of a sustainability framework for our local providers. But those challenges come with additional workloads, and you have to deal with the managed care plan and, aligning that. So it's really important that we figure out our strategies, not only for sustainability, but how do we maximize these opportunities in front of us? So specifically, the funding opportunities, as we've already mentioned, between ECM and community supports, the PATH funding, the IPP, and then there's also that community health worker with the Medi-Cal benefit. So we really want to look at these programs as, yes, offsetting county expenses, but really focused on the expanding of the services for this vulnerable population. And we'll get into a little bit of the technical pieces as to why. But as we go, I want you to think about how can we expand services. So our ongoing funding and county world is realignment. We've got our general fund, local dollars, Title 19. We know our home safe dollars are sunsetting. Our APS ARPA is a few months away. And so we really need to utilize this opportunity to transition from these temporary funding models to some sustainable funding models. And this CalAIM is an opportunity for that to happen. I think Gretchen said it best, but we earlier about working together and breaking down those silos. And I want to just take a moment here and plug in that includes in our own counties between fiscal and program. And so we really want to take a look at how our enhanced care management and community support services really intersect and complement what fiscal and program are already doing. And so a good first place, might just be to identify your existing funding sources and identify the gaps, right? What are those budget pain points? Something else at the county level, what are our semi or discretionary dollars being spent on? And that can include both realignment as well as general fund. And then we've got what upcoming changes, Prop 1, got a lot of things morphing, particularly on the behavioral health side, but there's a lot of crossover with the same population that we're talking about here that would be eligible under these populations of focus. And so best bang for the buck is really to align our existing programs with the opportunities to really maximize the funding. And so you may look at existing contracts that maybe include housing navigation or some care coordination, because many of our counties, we're already doing some of these things and we're contracting for them because we know they're best practice. And so you want to start with those areas. And then it can even expand into staff discussions, right? Staff that are actually providing care management or case management. I'm so sorry, Gretchen. Something is going on my screen. The PowerPoint gets super big and then it goes back small. So it might be a technical issue on my side, but didn't do that before. So it's interesting. Okay, next slide. Okay, so specifically, how do we do that, right? And why is it important? So the idea of blending and braiding funding, it's not necessarily a new idea, but it's really important because ECM and community supports, they cannot supplant, but they can supplement. And so what that means is we are actually enhancing the services. We're not removing our local dollars already spent. So remember when I said we want to focus on expanding services, that goes right along with supplement. We don't want to necessarily pull away those local dollars, but and which is why we focus on those contracts that are funded with those semi-discretionary revenues already. And this is really an opportunity for what we're going to call non-traditional social service providers to access Medi-Cal funding. And that's kind of new with this. And so for those of us in this adult population world, we haven't really had access to Medi-Cal funding. And so we're really delving into it. And then just a big picture piece. CalAIM, whether it be ECM, community supports in itself, is most likely not going to be sustainable for a county. I'm sorry, self-sustaining for a county or for a local provider. But we're really looking at it being a piece of that pie and blended and maximize other revenue sources that we're already drawing down. And that's how it turns into being financially sustainable. So braided funding in itself is when you just 10% here, 20% here, 30% here. Many of us probably already do this without even realizing it's a thing. And so each of those funding sources will have independent requirements and perhaps claiming attributes. But at the end of the day, that's what makes up our budget. So very similarly, we just want to add in this opportunity as one of those funding sources and really use it to fill service gaps and expand those opportunities and increase our local capacity for even providing those services in some instances. But I don't want to make it seem like it's all roses. It can be complex and challenging because of some of these things I just talked about. You have to track them separately. They may each have that come with their own claim process. And it really requires that strong financial oversight. But luckily, most of our counties, we already do that for many of our other sources. So it kind of just fit itself right in. And so specifically, some considerations when we're branding fundings is impacts on other allocations, particularly those social services. If you're not a super agency, you know, as you move someone in and out of, we'll just say like an administrative role on your county expense claim, that impacts other your percentages of drawdowns, right? And it can, you want to maximize allocation, so you don't want to shift dollars that you are currently using with a county allocation and claim CalAIM. You want to really maximize the unmatched dollars. So as a Medi-Cal source of funding, it can cause cash flow issues for some of our local providers as there are delayed payments, there are still denials. Oh, the screen just jumped and zoomed in again. I don't know what's going on. I'm so sorry, Gretchen. And then we don't want to get a local provider to ramp up and then all of a sudden not have the administrative infrastructure there. So it's really important that we work with our community providers to set up these billing systems and really understand what it's going to take on the administrative side to make this successful. So the best practices when braiding funding is really focusing gaps in services, unmet client needs, and that's going to vary county to county and where you're at in these things, and really focusing on sustaining and not replacing our funding, our services. And then you really need to do an cost benefit analysis, right? Evaluate the rates and reimbursement structure. We're not suggesting that all counties, jump in with both feet on this, but really take the time to figure this out because there are limits of these funding sources. Luckily, the PATH collaborative meetings that was mentioned earlier, they go on, and there's a lot of counties have done some of this work. So if you haven't been connected to them yet, you can definitely get connected. and reach across your systems. There's CalAIM has reached into the child welfare side that many of us partner closely with. IHSS, there's kids there. So share those resources and talk to other people. And just we're government, so when possible, small changes, incremental change. We're already used to that. So this practice lends itself nicely to that. And I know I've said it a lot of times, but one more time, no supplanting, we want to supplement. And many of us over the years, our budgets, our staff have been funded with grants. Supplanting is a big no-no. And really just if you're confused at all, really reach out to that TA. It's there for us. And then another thing just want to mention is that the payer of last resort. So a lot of our clients that we serve are what we call Medi clients. And so just want to remind that, Medicare must be billed first, and then Medi-Cal can only pay for the additional costs not covered. And I think Baljeet mentioned that, we do have some of our population that has that share of cost that then makes things not they're not eligible at that point. And so really important that if you focus in on a starting pilot, that you pick your pilot carefully to maximize, so you can really do that analysis for your county. Okay, so the roles for county departments in ECM and community supports. So counties are probably one of the most critical roles in actually implementing and supporting ECM and community supports. So we talked about referrals. There's been quite a few questions in the chat about how do we do a referral, but really the responsibility goes beyond just referring clients. Between building capacity, coordinating services, leveraging funding, and then it's been mentioned even becoming a direct provider. So growing that local capacity is really leveraging these programs and shifting those county costs to ECM for those services that cross over. And think about at the county level, things that will need to happen and could include data sharing, care coordination, and training. If we don't know how to make a referral to ECM, who's telling our providers how to make those referrals? So, we got to bridge that gap. We got to take on a little bit of that responsibility. And then really it is in our best interest to get our providers to understand these new funding sources through Medi-Cal. It's going to be a direct benefit to the county if they can become sustainable, or another little piece of their pie. They're not going to be coming back to the county to ask for those more dollars, right? Think about if we all have contracts that, I wish they did X, right? Well, maybe this is a way to get them to leverage those additional dollars, and now we can ask for one more outcome, and it's helping our client population at the same time. Really shifting those county costs allows the county to then invest in services for those non-Medi-Cal services, or also spending those dollars on the most complex cases. And that's really where that county support comes in. All right, so how do we do that? It's great that we have to do that, but what are the actual steps? There's a question. Would you please clarify how we can shift county costs to ECM as an ECM provider without supplanting? So Travis, right now, your county costs, your budget is probably made up of a lot of local dollars. And so if you're talking about staffing, we'll take a stab at that. If you're talking about staffing, so rather than pull your realignment or general fund for perhaps a match, if you are someone that's doing like a Title 19 drawdown, then you'll be able to shift that money to then further the services in the community. So it's shifting. It's not taking away those dollars. And then what that does is, if you're drawing down that ECM, that's a very reliable, sustainable source for your match. And then that service you can then use in the community to draw down that other piece. I don't know if that's what you were thinking, or Baljeet, you can take a crack at it in the chat and I'll keep, okay, perfect. So I kind of briefly mentioned it, but there's really what can we do and what steps. And so we talked briefly about a gap analysis, but to really fully engage with ECM and community supports, we really need to assess what's available, right? Who is already providing ECM and community supports? Decide the county's role by using that assessment, and then leverage the funding we talked about, building partnerships, and then expand capacity out there. So we're going to kind of, thanks, Baljeet. There's only 7 minutes left, so I'm going to kind of speed through these next ones. But like they said, they're going to be emailed out, and you guys can read the slides. So I'm just going to do the highlights. Is that the assessment, we talked about the PATH collaborative, identifying gaps. Step 2, use those results. There's a lot of focus on referrals. Talk to your MCPs, attend those meetings, and figure out where you can help facilitate those partnerships between the MCPs and the trusted community organizations, the people you already use and refer your clients to. Leverage revenue, we spend a lot of time, no supplanting. And then becoming a contracted provider, pros and cons there. So really do that financial cost benefit analysis. And then the big one is really build that capacity and infrastructure. That's really what we're looking for. You know, looking at your staff time study, but you can have a good example might be your AAA, the Area for Agency on Aging. They probably already provide case management, right, for those older adults, but it may not be Medi-Cal billable. So that would be an area to look into. And so next steps, just a quick guide for what thing, really start to those county contracts, have your conversations, convene partners, all this stuff that they've mentioned here.
Any questions for Melissa here? Lots of information, I know, but you'll get the slides. Okay, Travis, all right, Melissa, this is for you.
I can answer in the chat if you guys want to keep going.
I know we only have 5 minutes, so yeah, if that would work, that'd be great. So there's a couple things that are new. Again, don't want to spend time here, but they will be in the slides as reference points, what's happening in 2025. So we'll just keep moving here because I do want to get to a couple of other things. So one of the pieces that I think is really important, so we've talked about getting to know your managed care plan partners. We do know that the state is asking the managed care plans to take more of their net revenues and reinvest those in local communities. And so getting to know your managed care plan partners, so when they get to this point where they're having to reinvest dollars, you can help give them your thoughts about where some needs exist, what gaps exist. So again, trying to be at the table when some of these big decisions are being made, I would think is really, really important. So really encourage you all to get to know your managed care plan partners. We have a lot of resources here and they've been in the chat. They're linked in the slides as well. These are kind of the big picture ones. So the state websites for the different initiatives that we've talked about. So I encourage you all, if you have questions, a lot of the policy documents are linked here. And I know, Sharon, I'm going to turn over to you now as we want to wrap up. So,
Okay. Thank you, Gretchen, Baljeet, and Melissa. A lot of really good information, a lot of really great questions. And just so everyone knows, I did add our brown bag information. There will be a brown bag meeting coming up that will speak directly about the home safe funding ending and what community supports can help possibly for those clients that may still be in need of services. And then we also have a survey that if you can click on that, I'll show you a little QR code. There you go. So you'll be able to utilize that to do our survey, or I've added the link if that doesn't work for you. We also will have this recording on our CFPIC webpage under the adults box. So just click on that. You'll see all of our CalAIM support information, contact information, and all of that good stuff. So if you have any additional questions, if you need some additional supports, please feel free to reach out to me and I will do my best to get you connected. But with that, I think we are done right on time. Thank you so much, everyone.
thank you all. Enjoy your weekend.
Thank you.
Maybe we can take down the slides.
Any last questions before anyone hops off? Is everyone okay to get to the link for the survey? Looks like we're good. Thank you so much, Melissa and Gretchen and Baljeet. That was some great information and great presentation as always. So I appreciate it, and I definitely appreciate the adults' focus. So our folks on this call also, I'm sure, greatly appreciated that.
Yeah, later I thought one of the things to really hone in on the scenario is there is I think we would see a decrease in APS referrals if we do link members to ECM and potentially.
I would agree with that, specifically to the self-neglect cases.
Mm-hmm.
Stop the recording.